with our orthopedics and try and finish it off. Okay, so rheumatoid arthritis we have to do. So rheumatoid arthritis is a chronic non-separative inflammation of the synovial joints. So it is caused by exposure of genetically predisposed individual to infectious agent. It leads to autoimmunity and formation of immune complexes. These immune complexes are deposited in the synovial membrane, leading to chronic granulomatous inflammation of the synovial membrane. So diagnosis, you have acute symmetrical polyarthritis. So there will be pain and stiffness in the multiple joints, at least 4, and it'll be more in the morning. Most commonly it is seen in metacarpophalangeal joint and particularly that of index finger. Other joints affected are metacarpophalangeal joint of the hands, PIP of the intraphalangeal joints of the fingers, wrists, knees, elbows, ankles, hip joint, temporomandibular joint, atlantoaxial joint, and facet joint of the cervical spine. It will affect all of these. So examination, you have swollen buggy joints, intra-articular effusion, and synovial hyperplasia. Hypertrophy will be seen, and deformities will be there in rheumatoid arthritis. So in the hand, you will have ulnar drift of the hand, and you have boutonniere deformity and swan neck deformity. Boutonniere's deformity is basically one of the hand finger will be folded. Okay, it will be like one is extension and flexion, other one is flexion and then extension. That is Boutonniere and swan neck deformity, and ulnar deviation is it will deviate towards the ulna. Okay, so elbow you have flexion deformity, and in the knee you have early flexion deformity and late triple subluxation, which is posterior flexion and external rotation. Then you have ankle, you have equinus deformity, you will be on the tip toe, and foot you have hallux deformity and hammer toe. Hammer toe is similar to swan neck, flexion at distal and extension at the proximal, and hallux deformity is one lies above the other. And extra-articular manifestation of rheumatoid arthritis, you have vasculitis, digital arteriitis, Raynaud phenomenon is there, fever is there, skin lesions is there, chronic leg ulcers you have, peripheral neuritis may be there, mononuclear multiplex, and necrotizing arteriitis involving coronary, mesenteric or renal vessels. Then for rheumatoid nodules, you have commonest site is olecranon. Other sites you have dorsum surface of the forearms and tendinoachilles. And sinusitis, you have lung and pleura. Pleurisy will be there. Parenchymal nodules is there, and Kaplan's syndrome is there. Honeycomb lung is also seen. Then serositis of the heart, you have cardiomyopathy and pericarditis. Eye, you have iridocyclitis, and nervous system, you have peripheral neuritis and carpal tunnel syndrome. Others, you may be having anemia, Feltis syndrome, Sjögren's syndrome, and amyloidosis. So these are the extra-articular manifestations of rheumatoid arthritis. Then investigations, you have radiological examination, you have reduced joint space, erosion of articular margins, and subchondral cysts. All of them are seen in radiological examination. Blood, you will have an elevated ESR and low hemoglobin level. Rheumatoid factor, you can check with the latex fixation test or Rose-Wheeler test. And synovial fluid examination can be done, and synovial biopsy can be done. So staging, triggering, maturation, targeting, and fulminant stage is there. These are the 4 stages. First is triggering, then maturation, then targeting, then fulminant stage. Then differential diagnosis, it can be SLE, osteoarthritis, or psoriatic arthritis. So treatment, you have staged therapy. So you can in stage 1 DMARDS and NSAIDs, and synovectomy you can do, and joint mobilization can be done. Stage 2, you have NSAIDs, DMARDs, soft tissue repair and arthroplasty can be done, and splints can be provided. Stage 3 is only NSAIDs, and arthroplasty, which is joint replacement, has to be done, and orthodesis, which is fusion of joints, can be done, or you can do splinting and walking aids. So those are the stages. In stage 3, you cannot give DMARDs because it's already very much spread or severe case. So this is the treatment, and most commonly you have to write more about DMARDs. This book really doesn't speak a lot about DMA, a lot of things. Like DMARDs is such a big important topic, but they have literally given nothing. Just a second. Okay. So going on, we have gout, which is disturbed purine metabolism leading to excessive accumulation or impaired excretion of uric acid. Tissue of predilection are cartilage, tendon, and bursa of a patient. So clinical features: more than 40 years of age. Arthritis is most common in metacarpopharyngeal joint of the big toe. Bursitis is most common in olecranon bursa, and trophy formation is there. Deposition of uric acid in the soft tissue, that is called trophy formation. Then confirmation of diagnosis: you have ureate crystals in the aspirate from a joint or bursa. You have high serum uric acid levels. So treatment: you can give NSAIDs, uricosuric drugs, and uric acid inhibitors. Example they haven't given. You have to read that. Then hemophilic arthritis. It occurs due to bleeding disorder, occurs in male. Commonly affected joint is knee, elbow, and ankle. So you can do X-ray where you can see bone reabsorption, cyst formation, osteoporosis, and widening of intercondylar notch in the knee. So treatment is rest, factor 4 supplementation, physiotherapy can be done, bracing can be done, and operative correction of deformity has to be done. Then degenerative disorders, you have osteoarthritis. So in examination of osteoarthritis, you have tenderness of the joint line tenderness will be there. Crepitus on moving the joint can be heard. Irregular and enlarged looking joint due to formation of peripheral osteophytes will be there. Deformity, varus of knees, flexion, adduction, external rotation of the hip can be seen. Effusion will be there, and terminal limitation of joint movement is there. Subluxation is detected on ligament testing. So investigations, you can perform X-ray, and narrowing of joint space is there. Subchondral sclerosis is there. Subchondral cysts will be there, and osteophyte formation will be there. Loose bodies will be there, and deformity of the joint can be seen. So there is narrowing of joint space. Subchondral sclerosis can be done. Subchondral cysts may be there. Osteophyte formation, loose bodies, and deformity of the joint. These are degenerative disorder. So examination, there is tenderness on the joint line, crepitus on moving the joint, irregular and enlarged looking joint. An irregular enlarged looking joint. Due to formation of peripheral osteophytes. Then of course varus of knee, flexion, adduction, external rotation of hip. Effusion is a terminal limitation of joint movement, and subluxation is detected on ligament testing. Okay, so treatment, you have analgesics, chondroprotective agents, you have glycosamine and chondroitin sulfate. Vesicular supplementation, you have sodium hyaluronate. Then supplementary therapy, you have weight reduction, exercises, hot fermentation. Surgically, you have osteotomy, joint replacement, and joint debridement. Then afflictions of soft tissue, you have deuterance contracture, which is contracture of palmar aponeurosis, characterized by flexion deformity of one or more fingers due to thickening and shortening of palmar aponeurosis. So etiologically, it is hereditary predisposition is a cirrhotic patients and epileptics on sodium hydantoin. Okay, all of them are common for ruptus contracture, which is deformity of one or more finger due to thickening or shortening of palmar aponeurosis. Palmar aponeurosis shortening. Early stages, you will find that you have thickening of palmar aponeurosis felt at the base of ring and little finger. Later stages, you have flexion deformity of the metapharyngeal and pharyngeo-interpharyngeal joint. Treatment, you have mild contracture, does not require any treatment. Significant deformity, you have excision of palmar aponeurosis, subtotal excision. Then you have golfer's elbow and you have tennis elbow. Tennis elbow is lateral epicondylitis. Golfer's elbow is medial epicondylitis. At the origin of flexion tendons at medial epicondyle of humerus. Treatment is similar to tennis elbow. X-ray does not reveal any abnormality. Treatment, you provide analgesics, anti-inflammatory drugs. Local injection of hydrocortisone at the point of maximum tenderness can be done. Tennis elbow is inflammation at the origin of extensor muscle of forearm at lateral epicondyle of humerus. Clinically, it may be tenderness precisely located to the lateral epicondyle of the humerus. Pain aggravated by palmar flexing the wrist and with forearm pronated. Forearm is pronated, palmar flexion of wrist and fingers will provide pain. X-ray does not reveal any abnormality. Treatment, you have analgesics, anti-inflammatory drugs and local injection of hydrocortisone at the point of maximum tenderness can be done. Then carpal tunnel syndrome, you have compression of median nerve as it passes between the flexor retinaculum. So causes is idiopathic is the most common cause. Inflammatory causes, you have rheumatoid arthritis, wrist osteoarthritis. Post-traumatic cause, you have bone thickening after a Colles fracture, and endocrine causes, you have myxedema and acromegaly. Clinical features, most commonly it is in middle-aged women. Tingling, numbness, discomfort in the thumb and radial half fingers, that is in median nerve distribution, can be seen. Tingling is more prominent during sleep. So nerve conduction studies can be done. You will find delayed or absent conduction of impulses in the median nerve across the wrist. Treatment, you have dividing flexor retinaculum and decompressing the nerve. Then we move on to shoulder, frozen shoulder, periarthritis shoulder. It is idiopathic loss of resilience of joint capsule of glenohumeral joint due to adhesions. So clinically, you have pain and stiffness. Pain is worst at night. Treatment is self-limiting disease lasting for 6 to 9 months. And you can give analgesics, short fermentation physiotherapy, intra-articular injection of hydrocortisone. The stiffness can be prevented by continuous shoulder mobilizing exercise. It is loss of resilience of glenohumeral joints due to formation of adhesions. Eventually, I think it okay. It is a self-limiting illness though. Then we have decurrence tenosynovitis, which is a condition characterized by pain and swelling over the radial styloid process. Results from inflammation of common sheath of adductor pollicis longus and extensor pollicis brevis tendons. On examination, there is tenderness is localized to the radial styloid process. Pain is aggravated by adduction of tongue across the palm and radial deviation against resistance, which is Finkelstein's test, and palpable thickening of sheath. So treatment, you have early stage, which is rest of the wrist in crepe bandage, analgesics, ultrasound, radiation, hydrocortisone injection. So in chronic cases, you have slitting and excision of a part of the tendon sheath can be done. Then you have trigger finger of thumb, which is constriction of fibrous digital sheath. So free gliding of flexor tendon does not occur. Clinical features, you have pain at the base of the affected finger will be there. Tendon will get swollen with the proximal contraction and finger locking will be there. There is swollen tendon does not enter the sheath if the finger is straightened from flexed position. So from the flexed position, the swollen tendon does not enter the sheath. Trigger finger, free gliding of flexor tendon does not occur. Finger will get locked. Okay, pain at the base of the affected limb finger. Okay, treatment, you have local ultrasound therapy and local injection of hydrocortisone. Ganglion, you have cystic swelling on the dorsum of the wrist. Etiologically, it is some mucoid degeneration of tendon sheath or joint capsule. Treatment, you provide aspiration of the cyst, injection of ileus is given, and excision in case of recurrence is to be done. Then myalgia paresthetica, it is a feeling of tingling, burning and numbness in the skin supplied by lateral cutaneous nerve of the thigh. Etiologically, the lateral cutaneous nerve gets entrapped in fascia just medial to anterior superior iliac spine. ASIS, just medial to that, it will be trapped. So treatment, you provide analgesics, local hydrocortisone, and you do surgical decompression of the nerve. Then we move on to metabolic bone diseases. You have osteoporosis. It is the reduction in bone density due to decrease in bone mass caused by senility, post-immobilization, example bedridden patient. Post-menopausal is there, protein deficiency will be there, inadequate intake, old age, illness, and malnutrition, malabsorption, excessive loss, third degree burns, and chronic renal failure, etc. So it is decrease in bone density due to decrease in bone mass. Bone mass only is very much less. Okay, the endocrinal in Cushing's, you can see Cushing syndrome and hyperthyroid state. Drug induced, you have long term steroidal therapy, it may be seen, phenobarbital therapy, it may be seen. So clinical features, you will have pain, pathological fracture, dorsolumbar spine, Colles fracture can be noticed, and fracture of neck of femur is noticed. Colles fracture, fracture of neck of femur, dorsolumbar spine fracture. Then clinical feature, pain, pathological fracture. So X-ray can do wherein you find loss of vertical height of the vertebra due to collapse. Codfish appearance is seen and the disc bulges into adjacent vertebral body. The disc becomes biconvex. And ground glass appearance is noticed in the bone. And in metacarpal index, vertebral index, and Singh's index, which is quantification of osteoporosis, can be done. Then investigations, you have biochemistry, wherein you have serum calcium phosphate and alkaline phosphate, all are in normal. Densitometry is to check the density of the thing, of the bones. And neutron activation analysis, you have you can do. And bone biopsy is most common. Neutron activation analysis, densitometry, and biochemistry. Serum calcium, serum alkaline phosphates and alkaline phosphatate has to be done. Then treatment, you provide calcium supplementation, vitamin D, aldronate, calcitonin, tiperatide, and anabolic agent increasing osteoblastic new bone formation. You give tiperatide and anabolic agent you provide, this will increase osteoblastic new bone formation. Then moving on, we have rickets. Rickets is failure of normal mineralization resulting in softening of bones and development of deformities. Then types of rickets, you have type 1 and type 2 rickets. Type 1 rickets is due to deficiency of vitamin D and due to disturbance in vitamin D metabolism. Type 2 is due to defective absorption of phosphates through renal tubules and diminished intake or absorption of phosphate. Okay. So diminished intake, malnutrition it may be there, diminished absorption, malabsorption syndrome, gastric abnormalities, and biliary diseases, lack of exposure to sunlight may be there. Then disturbance in vitamin D metabolism, you can have hepatic factor like lack of 25 hydroxylation of vitamin D and increased degeneration of vitamin D in patients on prolonged anticonvulsant therapy. Renal factors, you have a lack of 1 hydroxylation, which is autosomal recessive, and unresponsiveness of target cell to 1,25 dihydroxy vitamin D also can be there, and renal osteodystrophy may also be seen. Hypophosphatemic rickets like X-linked dominant rickets, Fanconi syndrome, renal tubular acidosis, and oncogenic rickets also are different other types of rickets. So diminished intake, diminished absorption, lack of exposure to sunlight, disturbance in vitamin D metabolism, fetal hepatic factor, renal factor, unresponsiveness to therapy, renal osteodystrophy, defective absorption of phosphates through renal tubule, hypophosphatemic rickets, Fanconi syndrome, renal tubular acidosis, oncogenic rickets, diminished intake and or absorption of phosphates. Okay. Then we have clinical features. You have craniotapes, bossing of the skull, broadening of end of long bones, delayed teeth eruption, Harrison sulcus, pigeon chest, rachitic rosary, and muscular hypotonia. Radiological features, you have delayed appearance of epiphysis is there, widening of epiphyseal plates, cupping of metaphysis, splaying of metaphysis, and knock knees, bow legs, coxa vara, all can be seen. Treatment, you have medical treatment, loading dose, vitamin D 6 lakh units, maintenance dose 400 international units, vitamin D per day. Loading dose you have to remember, you have to provide 6 lakh units, and maintenance dose 400 international units, vitamin D per day. Corrective osteotomy can be done. Again, craniotapes, which is flattening, bossing of the skull is called craniotapes, I think so. Give me a second. Craniotapes. It is a condition in infants and children where there is softening or usually softening of skull bones, usually in the parietal and occipital region. Softening of skull bones. Okay. Softening of skull bones, bossing of skull, broadening of ends of long bones, delayed teeth eruption, Harrison sulcus, pigeon chest, rachitic rosary, muscular hypotonia. Radiological features, you have delayed appearance of epiphysis, widening of epiphyseal plates, cupping of metaphysis, swaying of metaphysis, and knock knees, bow legs, coxa vara, all can be seen. Then we have osteomalacia, which is dietary deficiency of vitamin D due to it can be due to undernutrition during pregnancy, malabsorptive syndrome, and after partial gastrectomy also it can be seen. Osteomalacia. Then clinical features, you have bone pains, muscle weakness, and spontaneous fracture. So radiological examination, you have Looser zone, which is a pseudo fracture, radiolucent zone occurring at the sites of stress. Then you have protrusio acetabuli, which is acetabulum protruding into the pelvis. So treatment, you have medical treatment, which is loading dose you provide, vitamin D 6 lakh unit, maintenance dose again for 400 international units, vitamin D per day, and your corrective osteotomy. It can be done. Same treatment as osteoporosis, rickets. Similar treatment to rickets. This is osteomalacia due to vitamin D deficiency and undernutrition during pregnancy, malabsorptive syndromes, and partial gastrectomy. Okay, bone pains, muscular weakness, spontaneous fracture. Looser zone, which is pseudo fractures, radiolucent occurring at sites of stress, protrusio acetabulum protruding into the pelvis. Then miscellaneous afflictions of the bone, you have osteoporosis, which is marble bone disease, and Albert-Schoenberg disease. This is an autosomal dominant condition. Dense brittle bones is there, marble bones, associated with severe anemia, jaw osteomyelitis, and cranial nerve palsies. Then we have Paget's disease, which is osteitis deformans, which is a progressive tendency for bone to get bent, thickened, and spongy. Most commonly, it is seen in tibia. Clinical features: 40 years of age most commonly affecting. Dull pain is there. Bowing and thickening of affected bones can be seen. X-rays, you find multiple confluent lytic areas with interspread new bone formation. Multiple confluent lytic areas with interspread new bone formation. Then you have bone scan, which also increased uptake. Serum alkaline phosphate will also be elevated. Complications, you'll have a pathological fracture and malignant change will be there. So treatment, you can provide a calcitonin and diphosphonate. Then we have Perthes disease, which is coxoplana pseudocoxalgia. So you have osteochondritis of epiphysis of femoral head. Osteochondritis can be seen of the epiphysis of the femoral head. So femoral head becomes partly or wholly avascular and deformed in Perthes disease. It is osteochondritis of epiphysis of femoral head, partly or wholly avascular and deformed. Etiologically, it is recurrent episodes of ischemia of the head, precipitated by episodes of synovitis. So staging, you have stage of synovitis, stage of trabecular necrosis, and stage of healing. So clinical features, you have 7 to 10 years of age patient is there is pain in the hip radiating to the knee, and limping or hip stiffness is there. Examination, you will have a limitation of adduction and abduction and internal rotation limitation will be there. There is shortening. Radiological examination, you will have collapse and sclerosis of epiphysis of femoral head. Hip joint space will be increased. So collapse and sclerosis of epiphysis of femoral head epiphysis. Then hip joint space will be increased. Then bone scan, you will see that there is decreased uptake by head of femur. Head of femur, there will be decreased uptake. Then treatment, head should be kept inside the acetabulum. Revascularization will take place. Head containment, it is achieved by conservative methods, plaster, splint, etc., or by operative contained osteotomy. So causes of avascular necrosis of femoral head, you have idiopathic is the most commonest, alcoholism, steroid therapy, sickle cell disease, patient on renal dialysis, patient on anti-cancer drugs, postpartum necrosis, Gaucher's disease, and Cassian's disease. All of this will cause avascular necrosis of head of femur. Treatment, you have femoral head is non-deformed, then core decompression and fibula grafting can be done. If femoral head is not deformed, muscle pedicle bone grafting using tensor fascial lata can be there. If advanced osteoarthritis is there, then you can do total hip replacement. Then torticollitis, which is a brain neck. It is deformity of the neck, head, and the neck is turned and twisted to one side. Causes, it can be congenital, infective, reflex spasm, neurogenic, or ocular, or others. So congenital, it can be sternocleidomastoid tumor itself. And infection, you have torticollitis, Atlanta-oxal infection, and labyrinthitis. Reflex spasms, you have acute cervical disc prolapse. It may cause spasm, therefore they will be spinning it. Spasmodic contraction may be there. Paralytic condition, spasmodic or some paralytic condition. So ocular, it may be compensated for the squint. So they'll be having a squint, so they'll rotate to one side so that they don't see 2 number. Then rheumatoid arthritis or spasmodic torticollitis can be there. Just a second. I don't think I explained this very well. So there is fibrosis and sclerosis. So stages, you have synovitis, trabecular necrosis, then you have stage of healing. So clinical features, 5 to 10 years of age, pain in the hip, radiation to the knee. It will go to the knee, and limp or hip stiffness. Normal, similar to a lot of congenital diseases or TB hip, same complaints of that. So limitation of abduction and internal reduction, shortening will be there. Collapse and sclerosis of epiphysis of femoral head and hip joint space is increased. So you can do bone scan, which will show decreased uptake by head of femur. Treatment is head should be kept inside a acetabulum when revascularization takes place. Head containment. So plaster, splint, etc. can be put, and operative containment osteotomy can be done. Causes idiopathic, alcoholism, steroid therapy, sickle cell disease, renal dialysis, anti-cancer drugs, postpartum necrosis, Gaucher's, and Cassian's. Femoral head not deformed, you can do cord decompression and fibular grafting. Femoral head not deformed. Muscle pedicle grafting using tensor fascial lata or advanced osteoarthritis. You can do hip replacement. Muscle pedicle bone grafting, cord decompression and fibular grafting. Total hip replacement. Okay. Okay. Then miscellaneous regional diseases, you have cervical rib, additional rib from 7 cervical vertebra attached to the first rib close to the insertion of scalenus anterior. Clinical feature, you have neurological and vascular symptoms. Neurologically, tingling and numbness along T1 dermatome, medial border of forearm and the arm, weakness and wasting of muscle and clumsiness. Vascular symptoms, you have compression of subclavian artery, gangrene of fingertips. X-ray, you can do well-formed ribs articulating posteriorly with transverse process of C7 vertebra, attached anteriorly to the middle of first rib. First rib will attach middle and well-formed rib articulating posteriorly with C7 transverse process. Gangrene of fingertips and compression of subclavian artery. Okay. Differential diagnosis, you can have a carpal tunnel syndrome, cervical spine lesions may be there, spinal cord lesions may be there, and ulnar neuritis may be seen. So treatment, you do surgical excision. Okay. Then genu recurvum, it is hyperextension at knee joint caused by polio, Marfan syndrome, Charcot's atrophy and epiphyseal growth defects and malunited fracture. So treatment, you provide braces and upper tibial corrective osteotomy. Then bow legs, genu varum, knees are abnormally divergent and ankles abnormally approximated. Causes may be idiopathic, post-traumatic, post-inflammatory, neoplastic causes may be there, bone softening may be there, stretching of joints and cartilage thinning can be there. Traumatic is fracture of the lateral femoral or tibial condyles, lower femoral or upper tibial epiphysis. Post-inflammatory may be lateral damage to the lower or upper tibial epiphysis. Maybe bow legs, a lot of damage can cause it. Post-inflammatory also it can be there. Basically damage to the lateral side of the lower femoral or upper tibial epiphysis or epiphyseal plates by infection or by trauma. Neoplastic, there is a tumor causing a growth disparity at the epiphyseal plate. Example, chondroblastoma. Bone softening may be because of rickets, osteomalacia, bone dysplasias and rheumatoid arthritis. Stretching of the joints may be because of Charcot's disease and paralytic disease. Cartilaginous thinning is osteoarthritis of the lateral compartment of the knee. Osteoarthritis of the lateral compartment of the knee. So treatment, you have to give a shoe with outer raise and surgical correction. These are the genu varum and genu recurvum. Okay, so loose bodies in the joint caused by osteochondritis, osteochondral fracture and synovial chondromatosis. All of them can cause loose bodies in the joints. So clinical features, you have there is sudden locking of the joint and perception of loose body within the joint you can have. X-ray will show loose bodies as radio opaque, and treatment, you have to do arthroscopic removal. Then 3 more topics are left. Okay, after that only trauma. I'll do trauma after a bit. So amputation, prosthesis and orthotics, you have disarticulation where a part of the limb is removed through the joint. Disarticulation, not arthrodesis. Okay, fine. Amputation, a part of the limb is removed through one or more bones. Indications are injuries, peripheral vascular disease, infection, example gas gangrene, tumors, nerve injuries and congenital anomalies. So types, you can do open amputation with a guillotine when wound is not healthy, skin is not closed over the amputational stump, and secondary procedure has to be done after some time to construct a satisfactory stump. But most commonly closed amputation is done where the skin is closed primarily and proper examination, everything is done. complication, you find hematoma formation, infection will be there, skin flap necrosis can be there, deformities of the joints is seen, neuroma and phantom sensation can also be seen. Then you have hemiarthroplasty, which is replacing only one side of a joint. Hemiarthroplasty, for example, head of femur is replaced with an artificial component while acetabulum is left as it is. Hemiarthroplasty indicated in situation where only one half of the joint is affected. Example, fracture of neck of femur. So prosthesis can be single piece, monopolar, or two piece, bipolar. Operative technique can be is of the following: expose the hip, dislocate the hip, resect the ends, prepare medullary canal for receiving the prosthesis, implant the prosthesis in canal and reduce hip and close the wound. Orthosis is improving functioning of the body by application of a device which aids the body part. So it can be some types. You have static orthosis, which is supporting an arthritic joint or a fractured bone, which preserves joint contractions in paralytic limb. And you have dynamic orthosis, which is applying forces to a joint which is damaged by arthritis. Muscles of the joint are weak. So uses of orthosis: you have immobilize a joint or body part, prevent deformity, correct deformity, assist their movement and relieve the weight bearing. Then above knee amputation is through the femur, below knee amputation is through the tibia fibula, knee disarticulation is through the knee, and Symes amputation occurs through the ankle joint. Those four things you have to remember actually. Symes you have to remember is the ankle joint. Yeah, okay. It can be through the bone or it can be through the this thing. Then orthosis, improvement of body function by application of device which aids the body part. Static orthosis or dynamic orthosis. Prevent contractures. Dynamic orthosis prevent apply forces to a joint which is damaged by arthritis muscle. Joint prevent deformity, correct deformity, assist movement and relieve weight bearing. Okay, so I guess yeah. Only trauma is left. Trauma is around 47 pages. 47 pages headline. So from 21 to 47, which is around 30 pages. But 25 pages to be exact. Okay, it'll take another hour to finish. But yeah, I'll do it after a bit. My pen also needs to be fixed. So yeah, I'll see you guys after some time.